Hello and welcome to today's video. This is Professor Dr. Aditi Aikat, and today I'll be taking through one of the cornerstones of community medicine, that is general epidemiology. General epidemiology comes across one of the most important concepts and building block of community medicine, which both at undergrads and postgrads level, a complete clarity is very essential. Since this is a very exhaustive topic, I'll be taking it up in 3 different parts. So let's begin. Basic understanding of epidemiology. Well, what do you see in this picture? Well, you can see a big elephant is standing and a lot of people are examining its each part. Some is checking the ear and is thinking maybe it's a fan. Some is checking the tusk and thinking maybe it's a spear. Some is checking its tail and thinking it to look like a rope. And there's somebody standing a little bit at a distance and observing the elephant as a whole. And is chuckling and saying it's an elephant because that little guy is an epidemiologist who watches the elephant from a distance and not only sees it as a whole, but also in context of all the other elephants in the herd. So that is viewing the elephant in totality. And that's how probably an epidemiologist is a little bit different from everybody else. So what does the word epidemiology come from? The word epi means upon. Demi stands for people. And logy comes from logos, which means study. So when we define epidemiology, it is basically the study upon people. As John Last put it very beautifully, it is the study of the distribution and determinants of the health-related states or events in a specified populations and the application of this study to the control of health problem. Let us understand this basic definition. Where are the points of emphasis? When we are talking about distribution, that is, we are studying the distribution, we are basically trying to assess a pattern in the whole scenario and generate a hypothesis. And when we are talking about the determinants of health-related states or event, we are trying to find out the underlying causes and test the hypothesis which has been generated to find out how right or wrong it is. Epidemiology basically looks into the frequency, distribution, and determinants. Frequency in terms of the disease, disability, death, and health-related events and states, and the measuring tools being rates and ratio. Distribution looks into, as we mentioned, the patterns in the community in terms of time, place, person, and generate a etiological hypothesis. And the branch of epidemiology dealing into is mostly descriptive epidemiology. Then we come to the determinants, and this is the part that deals with the testing of the etiological hypothesis. It means nothing that when we say X causes Y, it is just a statement, but it needs to be verified. And that is what testing of etiological hypothesis is all about, where we analytically look into the picture, whether that statement is true or not. And it is the analytical epidemiology that looks into this. So let us have a look to differentiate the clinical approach and the epidemiological approach, relating clinical medicine, community medicine, and epidemiology. How are they similar and how are they different? If you look at the total domain of public health, that everything that is health related events concerning the public. The clinical medicine as well as community medicine are part of this large domain of public health, where clinical medicine is focused at looking at the individual as a unit, with its diagnosis, treatment, and follow-up being the major parts. Community medicine is more focused on the community which it takes as a unit. It's an ecological study, and where we look at the group characteristics and assess the disease burden and use forecasting to project the future ahead. And then where does lie epidemiology? Epidemiology comes across a cross-cutting issue that is linked both to clinical medicine as well as to community medicine. And the one concerned with clinical medicine is called clinical epidemiology, and the other concerned with community medicine is called as community epidemiology. And both these areas find its application to gain holistic knowledge. So you can see how interconnected they are. So if we want to understand that where are the areas where we find the use of epidemiology, it is to study the historical rise and fall in the population, the community diagnosis, to plan and evaluate, evaluation of individuals' risks and chances, identification of syndromes, completing the natural history of disease, and searching for cause and risk factor. So when we said community diagnosis, it is very important for you to have a clear understanding of what it is all about. Because often in the short notes, we come across terms like community diagnosis, community participation, and things like that. So let's look at it. It is a comprehensive assessment of health status of the community in relation to its social, physical, and biological environment. The purpose being defining the existing problem, determining the available resources, and setting priorities for planning, implementation, and evaluating health scenario by and for the community. Let's have a look at the epidemiological parameters and find the scopes of measurement in epidemiology. It may be mortality, that is concerning death, morbidity, that is concerning sickness, disability, and natality, that is concerning birth issues, as well as measurement of presence, absence, or distribution of characteristics of disease, measurement of presence, absence, or distribution of environmental and other factors causing the disease, and measurement of healthcare need, demand, and utilization, that is management issues, and of course the measurement of demographic variables. So you can see the epidemiological parameters has a huge scope of application, and the tools of measurement that are of importance are rate, ratio, and proportion. They basically measure the disease magnitude. Now let's take one by one. What is rate? It is a measure of the frequency with which an event occurs in a defined population over a specified period of time. Because rates put disease frequency in the perspective of the size of the population, rates are particularly useful for comparing disease frequency at different locations, at different times, or among different group of persons with potentially different size population. A rate is actually a very good measure of risk. In fact, the basic difference between a rate and a ratio is that a rate has a time dimension to it, which ratio doesn't. So let's look at ratio, what it is. It is the relative magnitude of the two quantities or comparison of any two values. It is calculated by dividing one interval or ratio scale variable by the other. The numerator and denominator need not be related. In fact, they may be just two random quantities. Like when we are saying the sex ratio, the number of females to the number of males. Coming to the third one, that is proportion. It is the comparison of a part to the whole. It is a type of ratio in which the numerator is included in the denominator. So that is a major difference between ratio and proportion. In ratio, numerator is never a part of the denominator, but in proportion, numerator is always included in the denominator. So what's the formula that we use in calculating proportion? The number of persons or events with a particular characteristic is the numerator. Then the denominator is the total number of persons or events of which the numerator is a subset. And there is a multiplier which may be 10 to the power n. Usually the n is taken as 2 and often this is expressed as a percentage. So let's assess how far we understood this and find out from these examples which one is a ratio, a proportion, or a rate, or none of the three. Well, let's look at the first one. Number of women in state A who died from heart disease in 2020 by the number of women in state A who died in 2020. So if you look closely, the numerator is part of the denominator. Hence, this will come across as a proportion. Let's look at the second one. Number of women in state A who died from heart disease in 2020 and estimated number of women living in state A on July 1st, 2020. Now, this is a different one. Here you see there is a specific time frame mentioned, this July 1st. As we discussed, when in this kind of cases, there is a time frame mentioned, it is usually a rate. Number of women in state A who died from heart disease in 2020 divided by the number of women in state A who died from cancer in 2020. So it is presumed that those who died from heart disease are not included in the number of women in the state A who died from cancer in 2020. So they are two different random quantities. So this one comes across as a ratio. Look at the fourth one. Number of women in state A who died from lung cancer in 2020 divided by the number of women in state A who died from cancer. That is all types of cancer in 2020. This comes across as proportion. Then in the last one, there is the number of women in state A who died from lung cancer in 2020 and estimated revenue in dollars in state A from cigarette sales in 2020. So this is absolutely two random quantities and not related to each other, and hence this last one turns out to be a ratio. Now, after this, we will look at some measurements of mortality, that is death-related measurements. Of them, the major ones are crude death rate, specific death rate, case fatality rate, proportional mortality rate, survival rate, and of course, in this context, a very important thing is the standardization of death rates, which may be direct or indirect. But this part I'm not going to take up in this video, the standardized rates, because it requires a lot of explanation. It will take a lot of time, and I'll take up a separate video to explain you in detail to give you more clarity on this. And these terms which I mentioned right now, the crude death rate, specific death rate, case fatality, proportional mortality, survival rate, all are very important from the point of view of the examination. It comes in your part of your long question as well as it is given in the epidemiological exercises and asked in the viva. So let's look at crude death rate. It is defined as the total number of deaths in a calendar year per 1,000 media estimated population. So this media population is usually calculated on the middle of the year, that is on 1st of July. So here when we say CDR is equal to D by P multiplied by K. Here D is the total number of deaths registered during that calendar year and P is the total media estimated population on 1st of July and K is a constant and it is usually a practice to take it as 1,000. Now let's come to the second one, that is specific death rate. Well, defined as the number of deaths of population of particular age or age group during a year, supposing dx, per 1,000 of the median estimated population at that age group, that is px. So SDR is equal to dx by px multiplied by 1,000. So it is actually advantageous to use the specific death rate to prepare separately for males and females to get the age and sex specific death rates. The only mean of calculation of age specific death rate that is unaffected by the age composition of a population. The third one, that is case fatality rate. Well, case fatality rate is the number of deaths assigned to a specific disease divided by the number of cases of the disease multiplied by 1,000. It predicts the risk of dying if the disease is contracted. So if you are aware, and must be so, then you will be, must be lately coming to hear often that people are saying the Delta variant had higher case fatality rate, but Omicron is having higher infectivity but lower case fatality rate. That is, number of deaths from those affected are considerably having a lower rate. Now the proportional mortality rate. Proportional mortality rate is the number of deaths from a given cause in a specific time period, and the denominator is the total death in the same time frame, and the multiplier is usually 100. It is useful for identifying the leading cause of death so that we can assess when we are going for the program aspect, the budget rationing is done. Those are the particular areas and program interventions are thought of. These pointers towards making the right decisions. It gives the relative importance of a specific cause of death in relation to all deaths, and you can prioritize. Coming to survival rate. It is a part of the survival analysis, and it is the percentage of people in a study or treatment group still alive for a given period of time after diagnosis. Actually, it's a method of describing prognosis in certain disease condition. And it can also be used as a yardstick for the assessment of standards of therapy. So we can put down survival rate as the numerator being number of people alive at the end of X years, usually a 5-year survival rate, and even a 10-year survival rate is often used. So X may be 5 or 10 or whatever the study is looking at. And the denominator is the number of people alive at the beginning of that interval. And the multiplier is usually taken as 100. Now, as we discussed the standardized rate, we are going to take it up in a separate video. So I'll not, elaborate much, but just to mention that it is the death rate of population adjusted to a standard age distribution. It is calculated as a weighted average of the age-specific death rates of the given population and the weights of the age distribution of that population. As most of the causes of death vary significantly with people's age and sex, the use of standardized death rates improve the comparability over time and between countries. Because what CRUDE death rate actually doesn't give you, that it doesn't give you the, particular age group where you need to focus, where the deaths are more, where the weightages of this mortality rates are higher, is not reflected because it gives you a gross rate. So that is the place where this standardization gives you a much better reflection. And if we look at the basic difference while you are doing the epidemiological exercises, that when to choose the direct method and when not to choose the direct method. For the direct standardization, actually you require to know the age specific death rates, so be it mortality or morbidity in all population under study, and in also the indirect standardization. Under these circumstances, the estimated rates should be subject to substantial sampling variation. But in indirect standardization, it requires that we know the total number of deaths and the age structure of the study population. And thus, indirect standardization may be the only feasible method if age-specific death rates are not available. And indirect standardization is preferable when there are small numbers in particular age group. Now let us look at the measurements of morbidity. So they are incidence, prevalence, and of them prevalence, point prevalence and period prevalence, as well as in incidence the secondary attack rate, and the relationship between incidence and prevalence are some of the important aspects that we should be aware of. So let's take up the secondary attack rate. It is the number of cases of infection that occur among contacts within the incubation period following exposure to a primary case in relation to the total number of exposed contacts. The denominator is restricted to susceptible contacts when these can be determined. So basically what it works out that the primary case is excluded from both the numerator and the denominator calculation. So it works out to the total number of cases minus the initial case, and the denominator works out as the number of susceptible persons in the group, that is the contacts, minus the primary case, and the multiplier is usually 100. It is used to estimate the spread of the disease in a family, household, dorm or other group or environment, and it measures the infectivity of the agent and the effects of prophylactic agents like the vaccines. Now coming to prevalence. Prevalence is broadly classified into point prevalence and period prevalence. Of these, the point prevalence is defined as the number of all current cases, old and new, of a disease at one point of time in relation to a defined population. Now, this one point doesn't mean 10 a.m. or 10:21 a.m. It's not like that. It is for all practical purposes, may consist of a day, several days, or even a week. But a particular unit of time, that is what is emphasized upon. But when we talk of period prevalence, it refers to the prevalence measured over a longer interval of time, and it is the proportion of persons with a particular disease or attribute at any time during that entire time interval. Let's look at in a different point of view with some graphic help. So let's look at this green frame. Here we can see two green vertical lines. They are signifying the two time limits. At one end we have 1st of January 2020 and another we have 1st of January 2021. So the horizontal lines, both green and blue, are representing the cases, and the length of the horizontal lines are standing for the duration of the disease. So either they are stopped by death or by recovery. So let us look at the first one and find out in this particular time frame what has been the incidence. So as we discussed, the incidence is the new cases within a time frame. So here you see that from between new incidence between 1st of January 2020 and 1st of January 2021, case 1 has started before the time frame. Case 2 has started before the time frame and ended before the time frame. Case 3 has started within the time frame and has been continuing beyond. Case 4 has started within the time frame and continuing. Case 5 has started before and has continued to a certain extent. 6 has started within and stopped within. 7 has started beyond and continued beyond. 8 has started within and 9 has started within but continued beyond. And 10 has started after the stipulated time period. So let's see what are the number cases that are to be calculated while finding out the incidence. It is 3, 4, 6, 8 and 9. Why so? Because all these are starting newly within the stipulated time period. Now let's look at the period prevalence in the same frame. find out which are fitting into the period prevalence of 1st of January 2020 and 1st of January 2021. Here you see number 1 case 3, 4, 5, 6, 7, 9, 8 all are fulfilling the criteria to be counted into the period prevalence. Why? Because whichever cases are lingering into the period are to be calculated for calculating the period prevalence, because it encompasses both the new cases as well as the old cases. Now let's look at the point prevalence as on 1st of January 2021. So all the cases that are at that point of time crossing that green vertical bar should be within the point prevalence, because those are the cases that are there on that particular point. Let's see. Yes, see, it's case number 3, 4, 7, 8 and 9. So why 10 is left out? Because 10 has started way after 1st of January 2021. Why 6 is left out? Because it recovered or died before 1st of January 2021. So hope this gives you a greater clarity into the concepts of incidence, period prevalence and point prevalence. Another important question that often asked, in this context is the relationship between prevalence and incidence. So in a stationary population in which there is no migration of cases or non-cases, if the incidence, prevalence and duration of a condition remains constant, then the number of new cases that occur must be balanced by the number of exiting cases that leave the population through a death or cure. So in such a situation, the prevalence is a function of the incidence and the average duration of being a case. So for a rare disease, we can say prevalence is equal to incidence into duration. That is, P is equal to I multiplied by T. So you can see this, very popular picture of incidence prevalence, relationship of a bathtub where the tap water is adding water to the bathtub. That is the new cases coming in, signifying incidence, and the previous water that was there and the added water, there's the old and new course, that is all the water in the bathtub is comprising the prevalence. And if you see from the bathtub bottom, some water is coming out. So there is a continual loss also. That lost water is signifying the mortality, right? So what are the uses of prevalence? Where do we find it's functional? It is based on both incidence and duration of illness, and high prevalence of a disease within a population might reflect high incidence of prolonged survival without cure or both. Conversely, low prevalence might indicate low incidence, rapidly fatal process or rapid recovery. Prevalence rather than incidence is often measured for estimation of magnitude of chronic diseases, which have long duration and dates of onset that are difficult to pinpoint. And it also helps to identify the high risk groups. It also reflects the burden in terms of life expectancy, morbidity, quality of life or other indicators. And besides all this, it is used for planning and administrative purposes in consideration of hospital beds, manpower analysis, that is the inpatient analysis, giving it a help in the managerial sides. Now coming to a very important aspect of epidemiology, that is time distribution. To look at the time trends. And this one is also very important from your examination point of view. It is often given in the form of, a part of it is given in the form of short notes, and sometimes even long questions comes from time distribution and time trends particularly. So it is important you know it in detail. Time. So with this, we will call it a day, and I'll be definitely back with the part 2 where we will discuss one of the most important things, the different types of epidemiological studies and how they are different and how they are similar and where they find their applications. So till then, keep tuned, and any query, do check out my YouTube. The short link is provided here. Thank you so much. Hope it is of help to all of you. Happy studying.